This episode of That Podcast in Hutch is brought to you by me. If you'd like to learn about how you can sponsor future episodes of That Podcast in Hutch, please reach out to me at thatguyandhutch@gmail.com or through my social media channels, which are also That Guy and Hutch. Thank you. Hey everyone, it's That Guy in Hutch, Jason Probst, and you're listening to That Podcast in Hutch. And I've got my producer, Christopher Acker, with me today and to talk about this episode in the intro, because I had Lacey Stone on, and she and her family have owned the Medicine Shoppe here in Hutchinson for about 30 years. This is a locally owned independent pharmacy. And I asked her to come on specifically to talk about pharmacy benefit managers. And this is a group of middlemen, basically, for lack of a better word.
It's such a confusing group of shadowy figures, really, that's when you think about your healthcare, you think about your provider, you think about your pharmacy, you think about your insurance company. But this is another entity between all of those that's really pulling a lot of the strings, is what we learned. And I didn't know anything about PBMs before this episode. And it's really eye-opening to hear they just really have their fingers in every pie of the medical system.
Oh, yeah. Well, when Lacey talked about the vertical integration, she said, they are owning everything from the insurance company, they own the PBM, they own the pharmacies, they own the clinics, they own long-term care facilities. The amount of vertical integration and consumption that is happening and consolidation that's happening in healthcare is unbelievable.
It is designed to extract as much out of us as the consumers as possible.
Yeah.
It's not designed to support our health. It's designed to extract wealth from us.
And you say you didn't know about PBMs before, really?
Yeah, and I have a medically complicated history. I'm seeing doctors all the time. I'm going to the pharmacy all the time. I'm talking to my insurance company all the time. And PBMs are just they're obfuscated. They're shady. They're telling the insurance companies what drugs they can provide, what drugs they'll get more money for, which drugs to push. But they're operating so much behind the scenes. They're not out there. They're not being transparent.
No. And I think one of the things that came up yesterday is that there are three main companies that control about 80% of the drug market. So if you're being affected by this in your personal life because of their ability to control the market, and they have outsized influence in the market, one of the most concerning things, and this gets right to the point of why I wanted to have Lacey on, there is a direct connection that the PBMs are forcing the closure of locally owned pharmacies. And she brought in a map, and I'll share this in the show notes and in all the information I put out. But you can look and see that a lot of pharmacies in rural, small town Kansas have been forced to close. And a lot of this is because the PBMs are undercutting the local pharmacies and making it impossible for people to use their local pharmacies.
And it's entirely designed that way.
Yeah.
It's like when a Walmart comes into a small community and runs the mom and pop grocery store out of business.
Yeah.
And all of a sudden now you only have access to what the Walmart offers, and you no longer have access to the services that mom and shop store was offering.
Yeah.
And this is happening with our community pharmacies, that the community pharmacies where you can go in and speak to a pharmacist in person when you have questions about your meds, you have questions about your condition, you have questions, and we're losing that to these mail order pharmacies that are controlled by these PBMs, that are controlled by these insurance companies. And we're losing so many services that we don't even think about. How often do you think about the value that your pharmacy is offering you beyond just giving you your drugs?
Yeah.
But just in being a person there to walk you through, which if you're having a bad side effects to a drug, you can go into your pharmacy and talk to them about it, and they can maybe come up with alternatives or other solutions for you. And they're knowledgeable and they're willing to share that knowledge with you in a way that these outside companies are coming in and just all they care about is extracting the wealth. They don't care about your well-being. They don't care about your health.
Well, that's highlighted by some of the things, some of the tricks that she said they play on them that are designed to make sure that a place like the Medicine Shoppe doesn't get reimbursed for the drugs they've sold.
Yeah.
And you'll learn a lot about this from listening to Lacey. So I'm really, really grateful that she was willing to come on and visit with us. And I'm really glad that she got into the detail on some of these things. And believe me, we've just barely scratched the surface on this. It's very complicated. And as you said, very kind of shady in the shadows sort of operation. But this conversation with Lacey is really important. It's important to know the way policy at the state level and the national level ends up affecting something in your hometown, like your ability to access a local pharmacy. And this has an effect on a family. And you'll hear about all of these. This is a very passionate conversation, a very real conversation. And I think you're really going to enjoy listening to this perspective from Lacey Stone and her family's experience at the Medicine Shoppe.
And we spoke about this off mic after we recorded, but a very real example in my life was at the beginning of last year, I didn't have access to a medication that I need to function. Because of some technical glitch in the system.
Yeah.
Nothing of my fault, nothing. And because I was using our local pharmacies, they were able to provide me with samples until that glitch was resolved, which allowed me to continue to function as a member of our society.
Yeah.
And that would not be possible if I was relying on one of these mail order pharmacies controlled by these PBMs, because they wouldn't care.
Yeah. They just say this is what it is.
Yeah. They said, sorry, you don't get your medication this month.
Yeah. Yeah. Well, I think you'll all enjoy this episode. And I think, Chris had, as he said, he has his own journey with healthcare here that is we'll do that episode sometime too, where we'll talk about your experience with and intersection with the healthcare system. But if you are interested in finding out how you can take action on this issue, feel free to reach out to me at thatguyinhutch@gmail.com. I think you'll really enjoy this episode with Lacey and hope you enjoy listening.
The Medicine Shoppe. When you drop your prescriptions off, the personal care you'll find there will make you feel all better. The meds you need, delivered with speed. The lowest price is guaranteed. Get your prescriptions with no hassle. At 14th and Main at the Little White Castle. You'll feel all better at the Medicine Shoppe.
All right. Well, hey, I have Lacey Stone in the studio with me today, and I'm really excited about this. I've been working on this for a while and wanted to have this conversation because there's this thing called PBMs, and that stands for Pharmacy Benefit Managers, and most people, I think, don't know what these things are or what they do, but you should, because they touch a big part of your life in healthcare. They are basically a middleman between your pharmacy and the drug companies. And I brought Lacey in because her family owns the Medicine Shoppe here in Hutchinson. And she is going to help explain PBMs to us, but more importantly, explain how the current system that we have with PBMs affects locally owned pharmacies in Kansas, particularly in rural Kansas, and even in Hutchinson with her family store, the Medicine Shoppe. So Lacey, thanks for coming in today.
Yeah, thanks for having me.
So tell me, I don't know because I don't, what is a PBM? What does it do? What's its role in the system of healthcare and prescription drugs?
So it's kind of crazy because I found out through some research that PBMs have been around since the 1950s, but nobody really talked about them, or they weren't in everybody's business, it didn't seem like, until maybe the last 10 years, it seems like. Definitely the last 5 years, it's gotten really bad, where, yes, they're the middleman. That's kind of hard to describe, and I think that's by design. I think they want to be shady. They want to be in the shadows and for people not to really know that they're there. But what they do is they're the middleman, yes, between the pharmaceutical companies and the insurance companies and the pharmacy. They have their fingers in everything. And so they have a relationship with the drug manufacturers. It's kind of a toxic relationship where they get rebates from the manufacturers for putting the manufacturer's drugs on the insurance formulary.
And that is a list of, and people know this, but they may not know the term. A formulary is a pre-approved list of drugs that you can get for any condition. And if you research it, I've had to do this before.
Yeah.
If you have a condition, there's a list of specific drugs that your insurance company will pay for.
Yes.
And that's designed largely by PBMs?
Yes. It's all by PBMs pretty much. Yes.
And I think what I hear you kind of getting to is that maybe some of the drugs that end up on the list may be more rooted in their relationship with the drug manufacturer.
Definitely.
Okay.
Yes. So, for any condition, like for depression, there are 30 plus different drugs that the doctor could put you on for depression. They're not all equal in every way. Every single person is unique. Their insides are unique as well as their outsides. And that one drug may work for this person. One drug may work for your sister, but this other drug works for you. So they can't say, or they can, I guess, but they shouldn't say that this specific drug is the one you need to be on, because there are 30 different ones, and there are reasons that there are 30 different drugs, because they're all different. They all cause different side effects. They all have different efficacy. People can handle them better. So you and your doctor, have that relationship where you can talk about which drug is working for you and which one isn't working for you. But unfortunately, the PBM can dictate if the insurance company is going to pay for it or not.
Well, let's. I'm going to ask you to take me through an example, because I think that might be a good way to explain this, because it is a complicated issue and it's hard to explain. So my son has type 1 diabetes. And because of that, he's insulin dependent, so he has to have insulin. And there have been times in his life where Humalog is the approved insulin, and then he goes along and he gets that dialed in and he knows what to expect, and then all of a sudden they tell him, no, it's Novolog now. It's a different one. Let's say, let's walk through a customer experience. I go to my doctor and he says, I want the depression. Let's use that one.
Yeah.
But let's say he gives me a prescription for depression, and I take it to Medicine Shoppe. What happens at that point? You guys get the prescription. Take me through how that prescription is then managed through the PBMs and the insurance companies.
Okay, so the process is we type it into the computer. So as far as from our perspective, we type it into the computer. We submit it. And so in cyberspace, then it goes to where we think it's going is the insurance company, but actually the PBM is in charge of all of that. So the only people that the patient or us can get a hold of is the insurance company, but it's actually the PBM that's doing all this. So the PBM decides whether it goes through, so whether they will pay for it, the insurance company will pay for it, or whether it's rejected. If it rejects, we get a piece of paper out of our printer and it says what the rejection is, whether it's something that we just maybe did incorrectly and we need to fix it, overwrite it and fix it, or whether we need to call the insurance company who actually responds to the PBM to say what we need to do differently, whether we need to change the day's supply or something simple like that. Or if they absolutely are saying, this is not on our formulary, we will not cover this. So even though the patient and the doctor decided on this antidepressant, it's rejected, and then they might give a list of 3 other ones that we could try, or they might not, and just it's like a wild goose chase at that point. Like let's try a whole bunch of different ones to see, and so then the process is lengthened. So you can't get on your antidepressant right away then, which it already takes 30 days for an antidepressant to really work. And so then it's like a couple weeks later, finally communicating with doctor's office getting back with us saying try this one, and so on, to where then the patient doesn't have their med that they needed. So if they say a different one, then we can try that. And sometimes it requires a prior authorization where that means that we as the pharmacy have to call the doctor's office, say, hey, this didn't go through. They will not pay for it unless you call. So then the doctor's office has to have an employee dedicated pretty much to prior authorizations at all times. That person has to call the insurance company, which is actually dictated by the PBMs, and work out, whether or not the patient can be on this drug. So it's then not decided by any healthcare professional. It's just decided by these people that have no healthcare background. And, they say yes or no, whether they will pay or not. Sometimes they reject it altogether. And then the doctor, if they really want the patient on this med, they will appeal it. And all of this can take weeks.
Yeah.
And so,
meanwhile, the patient is not getting what they need.
Oh, yeah, exactly.
Hey, listeners, this is producer Chris. I wanted to jump in here as well. As we're talking about these depression medications and the process it's taking for a patient to get access to the medication that their doctor has prescribed for them, that now these PBMs and these insurance companies are deciding, well, maybe not. And then the process of going through and getting on another medication and another medication. I just wanted to jump in with some of my own experience of bouncing between antidepressants while you're waiting for the insurance companies to decide through the PBMs, through these processes to decide which medications they will cover, without even acknowledging whether or not those medications will work for you. Because as you were saying, we're all unique, and these medications are work differently for each person, particularly as SRIs and antidepressants. And they also each have their own separate, unique constellation of side effects. And for someone who it takes time for a antidepressant to build up in your body and for you to actually start feeling the effects, and then to switch is very hard on the patient mentally and physically, because they're experiencing the side effects, and then they're experiencing withdrawals, and then they're experiencing new side effects from a new medication, and then new withdrawals, because they're bouncing back and forth between these different medications. This is something that I'd experienced when I was going through my mental health journey of determining. I went through many, many different antidepressants that never worked for me. It turned out that it wasn't antidepressants. Antidepressants weren't what I needed. I needed a mood stabilizer because I actually have bipolar disorder and not depression. But I went through basically like sampling antidepressants through whatever the insurance company would allow me to be on. And it was an incredibly exhausting process. Yeah. And then when we did find medication that worked for me, my insurance company decided that it wasn't going to cover it. So that was fun.
And in these, the decisions are not, clearly the decision about which drugs are covered and how they're covered is not rooted in the patient care, right?
Yeah.
That, like, what factors are the PBMs using to decide whether the medication is covered or not?
Since it's so shady, we're not able to look into that. Nobody is able to look into that. It all happens behind closed doors, and we can't see any of it.
So you guys have no input on what should be covered. Healthcare professionals have no input on what should be covered.
No.
It's a pharmacy benefit manager making a list of drugs that they'll approve.
Yes. So working together with the pharmaceutical companies, and obviously each pharmaceutical company is going to tout their own drug as being the greatest one, and that one should be on the formulary. But really, it's all about the rebates.
Yeah. And then meanwhile, somebody like Chris is over
Yeah.
here dealing with
Yes.
a whole legion of side effects, and it's exacerbating his mental health situation and making it worse because he's not able to get stabilized because he's on one drug for a while, another drug for a while, and they're just bouncing it around to try to find these things that the insurance company will pay for instead of doing what the person on the ground, his doctor, actually says.
Yes.
Yeah.
Yeah, instead of my doctor, my therapist, and my pharmacist, who are all trained and all have my best interest at heart, I've been in pharmacies where they're like, we are so sorry. We know that this is what you need, but we also know that you can't afford it because your insurance isn't covering it.
Yeah.
And that's just heartbreaking.
Yeah. Oh, it's terrible.
Oh, it's terrible. I mean, the doctor feels terrible, the pharmacist feels terrible, everyone in the patient's life feels terrible, and a lot of times the patient ends up giving up as far as trying to pursue therapy because prescription therapy, because then at that point they're just like, it's too much. So if they're already dealing with a mental health condition, this on top of it is just exacerbating it. Yeah.
So you and I think it's an apt description. You said that the PBMs are shady.
Yes.
And they do. No, because I could go ask 10 people on the street what they know about PBMs, and they wouldn't know probably anything unless they work in this field.
Yeah.
And yet every single one of us that has health insurance and has a prescription drug is subject to this. There was a time, tell me if I'm wrong on this, there used to be a gag rule, that was years ago. This is one piece of law that we've been able to change in the last 10 or 15 years. It used to be that if a pharmacist could see that you would pay less for a drug out of the cash price than running it through your insurance because of the PBM, that they could not tell the customer that. Do you remember? Do you remember this?
We're legally not supposed to.
Yeah.
Which is terrible. I mean, basically it makes us either break the law or help our patients. And our whole goal, nobody goes into healthcare because they want, I mean, I guess you could go into healthcare because you want money or you want something else. But truthfully, you work so hard and you use so much of your heart and your soul in this field that, you shouldn't go into it for money, that's for sure.
Yeah.
But you go into it because you care about people.
Yeah.
And so you see that somebody could be helped in some way and you can't tell them. I mean, it's terrible.
So I want to dwell on this for a second. You're behind the counter and I come in for my prescription and you can see that if I pay for it out of pocket, it would be cheaper. Or you see any option that would save me money that goes around using the PBM. Under law, you're not allowed to tell me that.
With certain insurances, I believe it is Medicare.
Okay.
That is that way,
Okay.
So I think with the private insurance companies, it is different.
Okay.
But I believe that it's the government insurance companies.
But would a solid takeaway for any of our listeners be to ask that question?
Yes,
ask
please
at the
ask.
pharmacy.
Sometimes we really encourage, people to ask. Please ask.
Because if the customer initiates it,
if they
then
lead
does that,
it,
okay,
then it hopefully is different and
Okay, so ask for the information so you can get it. So this is fascinating to me, and I know from my time in the legislature, because I actually worked on this a little bit about 6 years ago, when I first learned from a pharmacist here in town whose office is now closed, the hometown pharmacy. He was talking to me about it, and I had no idea what this was, and so I started asking around about it, and basically got shut down. And what I learned was that we don't even require PBMs to say they're a PBM operating in the state of Kansas. Like every other part of, we require people to do this with their cars and get driver's licenses and everything else. But these PBMs are operating. We have no idea who the PBM, we do, but from a legal perspective and a regulation standpoint, it's kind of an unregulated industry in Kansas. There's no record of them operating in the state of Kansas. Yeah,
that's what we're trying. That's what KPHA is trying to go for, is transparency with the PBMs. So when they're trying to write this law, which actually it unfortunately just got pushed to where it definitely will not happen this year, and it's been pushed to 2026. Yeah. Which is also kind of shady. It seems like there's some weird stuff going on with that. But the transparency is everything. We're asking for a very specific fee, just so that everything is transparent, with what we're getting paid and then also what the patient pays, because this impacts everybody.
So let's talk about this legislation that you're trying to get. You basically want some sort of certainty in what the cost of the drug will be for you and for the patient.
Yes.
Because there's an important point here. Sometimes the PBMs are paying you. There's a situation where pharmacies are getting paid less than it costs them. because of the rebate system, which gets very, and it is, and I would like say to the readers or the listeners, this is a really complex issue, and the reason that it's hard to explain is because it's intentionally made hard to explain.
Yeah,
it's a intentional complication that makes it, and it's a layer of people making money, and they want to hide the fact that that's what is happening, and they're just complicate this. But are there examples where pharmacies are getting paid less than it costs to procure the drug?
So in the last year or so, it seems that about 75% of prescriptions filled we are losing on.
You're losing money on 75% of the prescriptions.
Yeah.
Due to the PBMs.
Yeah. That's it. That's all it's due to. Yeah. And so we basically at that point, again, a really hard decision. Do we lose money, which we do every single day, but do we keep losing money on this person's prescription, or do we have them go without, which is like terrible. Or, we could suggest they go to a different pharmacy, but sometimes they can't find one, or it's going to take forever, and they need it right now. And so it's a really terrible position to be in.
How does that business model work?
It's a losing business model.
Well, and you I'll share this with the, online, but you have a map here of local pharmacies that have closed across the state, most of them in really rural areas where they don't have another option for a pharmacy.
Is this basic? Is this part of the plan to push people towards their own mail order pharmacies?
Yeah. The intent is to close small pharmacies.
Oh, this is definitely the intent. So as far as Kansas pharmacies, in the last 10 years, 52 pharmacies have closed in Kansas. Last year, 10 of those closed. Within the first couple of months, I think just like 40 days of this year, 10 pharmacies had announced their intent to close. This is all Kansas, just Kansas. So more than 90% of Americans live within 5 miles of a community pharmacy. It's a really big deal. Community pharmacies have always been a huge part of the community. People go in for their vaccinations, their drugs, just to chat, basically therapy, all different things that they get from the pharmacist, which is the most accessible healthcare provider ever, with all healthcare providers, because they can just pop in and see them and they don't have to even pay anything to talk to them. And so what's crazy is we still have patients that we have lost to mail order companies that are actually in cahoots with these PBMs. But we have patients still call us for advice and all different things about their meds that they aren't even our patients anymore, because they can't get a hold of a pharmacist from their mail order company because they can't get those other services. The obvious service of a pharmacy is to fill your medications, but there are all these other services that you can't get from the mail order that you get at the pharmacy, and they still use us for those services, and they're unpaid services. And we don't turn people away for those or hang up on them. We answer their questions.
I think it's important to talk about a community pharmacist. People can go in and ask you a question about their drugs, or they can say, this is happening, or I'm going to start taking this supplement or whatever.
Yeah, over-the-counter drug.
You'll take the time to talk to them about, this interacts with that or whatever, and you get that real personal touch there.
Yeah.
None of this is happening with the mail order pharmacies.
Right. You can't even get through to them.
So why is the push to get people away from local pharmacies to a mail order pharmacy?
So there's this term called vertical integration, and what it means is basically so they're the 3 big PBMs. They control 80% of the market. So CVS Caremark, which is associated with Aetna, Express Scripts, which is association with Cigna, and OptumRx, which is in association with United Healthcare. They control 80% of the market. The vertical integration means that the same company that owns the health plan, the insurance company, also owns the PBM, the pharmacy, the provider services such as CVS Minute Clinics, and they're also buying up other small physician practices, and they own long-term care services. So they own every part of healthcare.
From top to bottom.
Yeah.
this is kind of, I feel like I should want to throw up in my mouth a little
Yeah.
bit.
It
It's
makes
so
me really
gross.
emotional, actually. Yeah.
It should, because it's like, because your family's been in this for a long time, and it's just a gross consolidation of healthcare.
Yeah,
That's
it's
supposed to be built around
disgusting.
people.
Yep. It's supposed to be individualized care.
Yeah.
There's no individualized care with this.
No. In this system, we are all, I usually don't get this agitated in a podcast, but we're just we're just a resource that's being mined,
Oh, yeah.
right, for
Oh,
money, right? And because if they have, and from top to bottom, if they're buying every level of healthcare, and this has been going on for a long time.
They've been building it for a long time.
They've been building
Yeah,
it for
sure.
a long time. And originally, the idea, as the PBMs were touted, was a way to lower the price of prescription drugs through the power of negotiation.
Yes.
Right?
Yes.
But now they're integrated into the healthcare system. So one of the things that, because they own every part of this, one thing they're doing is undercutting local pharmacies and steering people to their own pharmacies. Is that right?
Yes.
Okay.
So the copays could be a lot less through the mail order pharmacy than through a local pharmacy. And there's
for
nothing we
exactly
can
the
do
same
about
drug.
it. Yep.
There's another component to PBMs that I think a few people know about. It's this rebate component, and I know that initially when we first started hearing about PBMs, the idea was that they would save money through their negotiating power, and they were big enough. But part of the way they do that is they would negotiate these drug rebates with the pharmaceutical companies, and then they would use that savings to drive down prices. But
Right.
really, this is how, at least it has evolved over time, but initially the rebates were being pocketed, and
yeah.
this is how the PBMs made their money.
Yep.
Can you talk about that rebate system a little bit? Now, you're not involved in any of the rebate stuff, right?
Right.
This is all between pharmaceutical companies and PBMs.
Yeah, I think that sometimes people think my copays are getting higher, so the pharmacy must be making more money, which is the furthest thing from the truth. It does seem like all of the rebate money is just going into the pocket of, you could say the PBM, but since we talked about how that same company really owns all of it, it's the insurance company, the PBM, everything they've bought, which is, the pharmacy and the doctor's offices and the long-term care and all of it. But yeah, those drug costs have actually just gone up over time, and they just blame each other. The drug manufacturers, the big pharma, and the PBMs, they're in a relationship, and it's kind of a mutualistic relationship, but they also are very toxic because they blame each other, publicly for driving up the costs. So the PBMs say that it's big pharma, and big pharma says that
But
it's
meanwhile,
the
they're both
PBMs.
making more money.
Oh yeah, they're both just filthy rich, and the patients are having to pay more money for their drugs, and the pharmacies are closing because they don't have any money. So, yep.
So what happens, so I know you guys visited Topeka and you're trying to get some legislation passed. What happens in these small towns when their local pharmacy closes?
Well, yeah, then they don't have that pharmacy that they can go into for all of these different services, for vaccinations and for their over-the-counter products. They have to get their prescriptions through mail order, and they can't get a hold of a pharmacist. And yeah, I mean, it could only be detrimental to the community.
And a lot of times, aren't we dealing, like some of these areas, as an aging population, maybe not comfortable
yeah.
with ordering things online.
Oh yeah.
And most of the mail order pharmacies do everything online.
Right.
So now you have people
Some
that
of
may
them
not
just
be
go
able to
without their
access.
meds.
Yeah, and they
Oh,
may not be
totally.
able to access. Have you seen that before or heard stories about that before, where people are just not getting their medication because it's too overwhelming?
Yeah, definitely. I mean, a lot of people, we even see it here, with signing up for Medicare D each year. A lot of people don't have people in their lives, kids, grandkids, somebody to come over and help them sign up. And actually, we legally can't help them sign up for Medicare D because that would be, swaying them. We can't, steer people, but the PBMs can. So, but anyway, yeah, there are a lot of people that don't have anybody. And that's why it's so good to have resources like the Department of Aging, to help people with that kind of thing. And I hope that other communities have services like that as well. But as far as helping them with all the online stuff with getting their drugs. I don't know. I'm sure that it's just detrimental. I mean, just like we talked about people, going without their antidepressants or whatever drug they need, older people often go without what they need, especially when the cost is too high.
Yep.
They just make that decision to either take one every other day, even though it's prescribed one every day.
Yep.
And some drugs just don't work that way.
Yeah.
You have to have that coverage. You have to have your blood thinner every day. You can't take one every other day. Then you're not protected.
Yeah. You see that? Do you see a lot of rationing with people?
Yeah, people definitely
As the cost,
ration.
because they're on fixed incomes, their income's not going up.
Right.
But the cost of everything else has gone up.
Yeah, so what are
Groceries
they
have gone
supposed
up
to
and
do?
drugs have gone up. Yeah.
I know with my artificial aorta, other people who've had similar surgeries have also had artificial valves put in. If you have an artificial heart valve, you can't skip your medication.
Yeah.
The blood thinners that are the anticoagulants.
Oh,
that
yeah,
keep
yeah.
the blood from clotting in
Right.
that system. You can't skip that one day. And if people are, and then that brings on issues of what happens if there's a bad snowstorm and the mail's delayed.
Right.
Yeah. Or mail services, I know,
What if something else
privatized
gets-
or made delayed. I mean, we had a lot of delays in the mail the last couple of years, right? Just in general.
Yes, there have been multiple times over the last many years that, like the Highlands fire 7 years ago or so, and then there have been different storms that mail has been delayed. And when those things happen, a community pharmacy is who you work with to get some of your pills. You can show them a bottle, or even if you don't have a bottle, the doctor can call and just explain the situation or whatever. And you can work out maybe a cash price for just a few pills. That is only a community pharmacy sort of thing that that we do. And we have had many situations like that where we've helped people, and like COVID, going to their cars to give their vaccinations, or going to their houses. We went to people's houses sometimes, going to nursing homes. We don't charge extra, to go to nursing homes to give vaccinations, but it's just those things that a community pharmacy is really the only one that does those things. And so if we all die, then what happens?
Yeah, then there's a huge
those
hole
services
that's
are
left
gone.
in the community.
Yeah.
When you started talking about the vertical integration, you got emotional. Can you talk about that a little bit? Like why that hit you so hard?
Yeah, I mean, I think it's just because, like I said before, all people pretty much that go into healthcare go in because they care about people and they want to make a difference in their lives. And when you start thinking about how this vertical integration thing, like one company can own everything almost, and you don't feel like you're really making a difference anymore. You just feel like everything is already dictated, like the way it's going to be.
Yeah.
And what difference am I making? And if all of us healthcare providers start feeling that way, then we're not doing our jobs to the best of our abilities. And we just have to get ourselves out of, I have to tell myself every day, just stop thinking about that and just keep helping people for as long as you possibly can. My dad has owned the Medicine Shoppe for almost 26 years, and it's just been a huge part of my life. I was 6 weeks old when he graduated from pharmacy school, and so he's been a pharmacist for 38 years, and it's just, I always wanted to work with him. I always wanted to help people with him, and I'm living my dream, but I just hate the fact that he at 67 is having to deal with this crap, and he would have probably truthfully sold a few years ago, if it wouldn't be for me and the other pharmacists and staff. So he basically stays open so that he can have, let us have the job that we want and help people. So he stays open for his patients and he stays open for his staff, and really not for himself because he's not making much money at all.
Yeah.
So that's why I get emotional.
And thanks for talking about that, because it's like, I know it's very personal. Does it feel too like it's like the whole system has kind of like violated the spirit of what this is supposed to be to you a little bit? Like,
it's not fair that these billionaires, can own healthcare. Like healthcare is supposed to be for the people. It's supposed to be individualized. Like, we're all so different, and they come in just like with everything else and just swoop in and buy it all, and we can't do anything about it. But we're trying to do little things, and so we definitely don't want to be depressing. We want to be positive, and we're definitely trying to do something just like many people in healthcare are trying to do. I mean, the doctors and nurses are suffering on their ends as well with all these prior authorizations. It takes away from their time being able to care for patients.
And it's ultimately the prior authorization thing is driving up. It's
Yes.
another element
It's
that's driving up
as
the
well.
cost.
It's steering as well.
Yeah.
I mean, they want people to just forget about it.
Yeah.
They want the doctor's offices to give up. They
Yeah.
want the patients to give up. It's just, and I haven't even talked about the audits that they do of the pharmacies, that they will come back and audit us and say, and it's always on the expensive meds, of course. So it's always on the inhalers.
These are the PBMs?
Yeah.
Okay.
So they'll send us a letter and say, we're auditing these prescriptions, and they'll have like a list of 30 different prescriptions. So we have to take the time to go and look all of those up and get them all the information. They have to have signatures from the patient. So there's this one really weird thing that with nebulizer meds, they have to be picked up and signed for on the day they're filled. So let's say the doctor's office calls in a nebulizer med and we fill it, and oftentimes the patient doesn't come for a couple days, a week, whatever, and it sits there on the shelf. Since the patient isn't signing for it that day, we don't get money for it. We just don't get paid. So we have purchased the $500 nebulizer med.
Yeah.
We give it to the patient, but we don't get paid for it because the patient
doesn't come
didn't
in
sign
that day.
for it that day.
Unbelievable.
It's just these little things, these little, are ways to just completely take us down.
It's like you're being harmed by 1,000 cuts, right?
Yeah.
Like it's death by 1,000 cuts.
Oh, yeah, for
just
sure.
a nick here and a nick there and a nick there, but it bleeds you dry.
Oh, yeah. That's why some of the bigger pharmacies, and they have, enough of things that they have to deal with as well. But some of the, the chain pharmacies, like, Kroger, Walgreens, Walmart, they have to deal with these things as well. But they have people that they have hired for their whole company to deal with it. But us independent pharmacies, like, we have to deal with it at our little store.
Yeah.
So we have to hear about all this, be watching the news, be reading about things all the time so that we know what's going on.
Yeah.
So we do that in our own time, know, and then we come to work and we're like, oh yeah, we need to be doing this because we heard about that. We could be losing money on that. So it's so much work other than just what our job is.
Wow.
It's crazy.
Do you, from your perspective, if there was a magic wand, Malcolm Gladwell does this experiment with a magic wand, and you could do whatever. What would you make this system look like? What would you do to make this system work better?
So what some people are trying to do is get these little PBM companies going and make them transparent so that they can take some of this business away from these big companies. But it's so much work for them. And I am not well versed in all of this, but I know that there's one that they've done some work in Western Kansas, and I'm not sure how far that they've gone, but they talk to employers and they try to work out like a private insurance situation. And so it's supposed to be, better for their employees. It's supposed to be better for the pharmacy. It's just so much paperwork and so much legal. So you obviously have to know what you're doing in those realms, but I think there's some grassroots efforts going on to
try to create like a local version of a PBM that would be more transparent with the pharmacies and work kind of on the benefit of the pharmacies.
That isn't owned by some huge conglomerate. And
it sounds like it's going back to do what PBMs had originally said they were trying to do, which was negotiate better drug prices.
Yes, definitely.
But isn't what's happening with modern PBMs because of that vertical integration?
Yeah, they've become greedy just like the drug companies, and so
and also just the nature of like markets and in business a lot is a constant growth, right? So they're not. It's like the orientation changes, and it's less about serving people and more about making money. And once the making money becomes the focus, then we abandon the principle of people altogether. Right. And there's pressure that if you don't make more next quarter than you did last quarter, then investors get weird. And there's a constant drive to just try to make more profit and make more money, which ultimately pushes the prices up for all the consumers.
Yes, definitely.
Not a very competitive market at all. I always joke with people, there's no such thing as a free market. There's protected markets, and there's markets that are not protected, and it's always friction between those two.
Yeah.
And in your case, these pharmacies are being actively driven out of business by big business.
Yeah.
By the biggest companies, insurance companies in the world are driving small local pharmacies out of business.
Yep, definitely.
I like this example of like the nebulizer. What are there other examples you can think of like weird little wrinkles in the way you're reimbursed on things that people would be interested in knowing? We know that you're not supposed to talk about things unless patients ask, even if you see it there. We know that like if you buy some medications and they don't get it to that patient that day, then you don't get paid for it. We know that you're being paid. You're losing money on a lot of drugs. What other things are out there?
So another one that we recently were audited on, and we, I think, lost some of the money in the audit because of this, is when we deliver meds, which we do for free. We, use our gas, we use our, time, our money to pay the delivery people, all of this. And it's all free. And we deliver multiple times a day, all throughout the day. So, in theory, as long as nothing really goes wrong, somebody could get their med delivered that day, even a couple hours after the doctor's office calls it in. Well, we received an audit that said that some of the signatures that we submitted for those meds that they audited were not good enough. So basically, some people literally cannot sign.
Yeah.
So if it's not a narcotic, sometimes we can leave it at their door. So we would say left in door or something like that. And that those signatures were not good enough for the insurance company to prove that the patient got their med or whatever. So, we're providing this free service to the community, trying to do our very best to get the patients their drugs that when they cannot make it in, and they, tell us that our signatures are not good enough.
Meanwhile, if I were to order through their pharmacy, I'm not signing anything. I'm just clicking a box.
Yeah,
they have no
definitely.
idea if it's me on the other end or not.
Right.
They might be able to figure out if you're a robot, but...
Right, that's about it.
Yeah, but that's about it. They don't know if I've got a kid over there doing this for me or something.
And they send meds. That's another thing is the mail order companies, they send meds no matter what.
Yeah.
Whether you order them or not, they're just sending them constantly. So we have had people that their family members have passed away, and we'll destroy drugs for you. We have this box that we send in, and it destroys drugs, and people will bring in boxes and boxes of insulin, of nebulizer meds, of all this stuff for us to destroy that the mail order companies
Just
had
kept
sent them
sending.
over and over and over again. So it's like thousands and thousands and thousands of dollars of meds that this person never used because they just sent it over and over and over again, like way too much supply. So it's all of this waste.
Yeah.
And they try to get us on fraud, waste, and abuse laws, but they are just constantly wasting.
So they're sending drugs to people that aren't alive.
Well,
or,
no.
or
They haven't died yet.
They haven't died yet, but they're not
But they're
using
just sending it constantly. So, they may use this much each day, but they're sending just way too much. They're sending it every possible time it could possibly be filled.
Okay.
They're filling it.
Okay.
Because their pharmacies are in cahoots with the insurance company, in cahoots with the PBM, in cahoots with all of it. So they're allowed to do that,
And that's just clearly a money-making thing, right?
Oh, yeah.
Like everybody along the chain is making money.
Yeah.
And then, God, the irony of this is unbelievable because they're doing that. There's nobody there to physically receive the drugs. There's nobody signing for anything. And then they're coming after you and using that to take money away from you.
Right.
Because you're actually physically delivering drugs to people who can't. And we all know people that they can't hold a pen or they're or
for
anything.
sure.
Yeah, things like
Yeah,
that.
definitely. So they need us to, say this certain thing on. And it's all just a ploy to not have to pay us. I mean,
Yeah.
obviously,
Yeah, it's just it's just a way to not pay you.
Yeah.
And to dishearten you.
Oh,
right?
yeah.
At some point where you're like,
we'll give up, just like
Just
the
give up.
patient gives up when
Yeah.
they have the prior authorization and they can't get their med. We give up, and you don't blame the pharmacies that do. And especially if it's an older owner
Yeah.
that doesn't have younger people to kind of help them with these different things, it's so hard,
Yeah.
And we have 4 pharmacists in that tiny little building, but we all are working constantly
Yeah.
on all of this stuff,
wow, it's so crazy to me. Tell me, so you went to talk about this legislation, try to create some transparency with the PBMs in Kansas. Give me a few more details about that legislation, and then talk a little bit about how you felt. You said it got pushed off to next year. And my experience in the legislature is you start bringing up PBMs and people want to shut you down right away because nobody seems to have an appetite to take on these giants.
And I guess that's what it is, because it seems so obvious. Of course, from my perspective, it seems obvious, but it's like not partisan, it's not like the Republicans or the Democrats. So I just thought,
These pharmacies are closing in very Republican areas.
Oh, totally.
Yeah.
So I just thought, okay, well, everybody will be on board with this. Everybody loves small business, but also I look at the world through rose-colored glasses. But I mean, I just thought before we went, who wouldn't be on board with this? Everybody says they're into small business. Like, this is just a duh,
Yeah.
And so when KPHA was kind of talking
and that's
us
the
up,
Kansas
Pharmacists Association.
Okay.
Mm-hmm.
Okay.
And we had so many pharmacists there that day. I think there were 400 plus pharmacists and staff members there to all work together on this and to go talk to all the representatives there. And I think that for the most part, the representative meetings went well. Everybody talked to us and did a really good job with that. But as far as the feedback we got, a lot of them told us, well, I'm for this, but it'll never pass this. You obviously know everything about that whole process, and I do not. But they would pretty much say, no, the lobbyists will make sure that this doesn't pass.
The lobbyists for the insurance companies.
Right.
Yes.
Mm-hmm. Because they have all the money in the world.
Yeah.
Because they own it all.
Yeah.
So it was really amazing, and it was a great day, and it was it made us feel like, okay, we actually can do something. But then when we basically learned, okay, so no, they don't only own this, and this, but they also can just basically pay off politicians. I guess that's what is going on. So yeah,
Well, because
we can't do that.
If you have individuals telling you that in the legislature that they support it, but they're and what I will tell you, this is what I was told too when I asked about it. I was basically told. I mean, I had a big meeting with the insurance commissioner and a number of people, and it just, first off, it was hard because nobody understood it. And that is a challenge in itself, to try to get, this is an invisible system, largely invisible by design.
Yes.
Nobody knows about it. Even people in government don't know about it. And when I first started asking about it, what I found was most people in government had no idea what was happening.
Right.
And then I talked to the insurance commissioner and had a number of people there. But basically what I was told is if you start talking about PBMs, they will bring in an army of new lobbyists, not even the lobbyists that are already in the building, but they would bring in an army of new lobbyists from D.C. who would make sure to kill it.
Yeah.
And there's not been, people are learning about it, but you're right, there's just very little appetite. People just do not want to take on hard battles, and this will be a hard battle.
Yeah.
But it's an important one because it's affecting our health and our well-being and our pocketbooks. And it's so important, I think. That's why I'm really appreciative that you were willing to come on, because people need to understand how this system is impacting them. And it is directly responsible for the increase in, it is not the only reason for the increase in drug prices, but it is directly responsible for at least part of the increase in drug prices. Is that fair?
Oh, yeah, definitely.
Yeah.
Them and the pharmaceutical companies are the two huge reasons.
And the story you told me about the sending drugs beyond just auto refilling, it's like that's so much waste. There are people, while that's happening, and they're doing that so that every layer, they can create money at profit at every layer of this. There are also people who can't get any of the drugs they need.
Right. Yep.
Oh, it's so maddening.
Yeah. Yep, definitely. And there isn't really a good system of like, okay, I have all this extra. Do you need this? Could you use this? There's no really system for that.
Yeah.
And I think that's
Well,
by
actually,
design, too.
that's also criminalized too, I think, right?
Yeah.
If I have extra drugs, it's illegal for me to go sell those or
Oh,
give
of
those
course,
to people,
sell.
right?
Yeah, definitely. It has to be like under the table sort of
Yeah.
thing. But yeah, so that's one of the reasons why there's no system for that. But it's crazy how they can do all these things that are so shady, and all these people just want to help each other, and we can't.
Can't do like a med share network or anything like
Right.
that. I know when Mitchell was diagnosed with diabetes, he was like 12 or 13 years old. We were lucky that a family who had their child had diabetes and talked to us and kind of walked, because it's a very shocking and unsettling thing to realize that your son or child has any illness, but that's a big thing to consume. She told me that in their experience, things had gotten better between when her kid was diagnosed and when ours was. And she had said that there was like an underground network, and she was trying to find insulin and testing strips. And she said, the testing strips was a thing that was so expensive, and that the insurance company, and we dealt with this too, would only pay for a certain number of test strips. And anything beyond that, we had to pay out of pocket. But the number of times they allowed him to test a day didn't really account for any variation in blood sugar. Like if he needed to test because his blood sugar was out of whack, and maybe this day he tested 5 times instead of 3, and you run out of test strips early, you're just out of luck.
Right.
Yeah. But she said she would find test strips from people who had been oversupplied.
Yes,
and
exactly.
was trying to find those
the
on
older
like a black
people
market.
who have gotten it all from, because the insurance is running their Medicare D just over and over and over. You know, so those people that have excess, then they can share. Yeah. It's crazy.
Such a crazy system.
Yeah.
Tell me what else you wish people knew about both PBMs and local hometown pharmacies.
About PBMs, I just want people to just start questioning things more. Call your insurance company and ask them questions and see what they can answer. Maybe if we bug them enough with this sort of thing and say, okay, so how much money is, the pharmacy getting? How much money are you getting? Are you owned by, I'm not saying the person you're on the phone with is going to know those answers, but maybe ask for their supervisor, or maybe, but if you have something that you need, if you need a med, that your doctor has prescribed, do everything you can to get it. And the healthcare population, we will help you in any way we can, but you need to advocate for yourself as well. Don't just lay down and accept the fact that you can't get it. You can get it. You just have to keep going. You just have to call them and bug them over and over and over again, and just call that number on the back of your card and do that and keep going. As far as local pharmacies, it's hopefully it's not a thing of the past. We have a billboard at on one of the sides of the Medicine Shoppe that's all the pharmacies that came before us in Hutchinson, and it just shows. And since then, a couple more have left us, but we're all in this together, and it is a competition as far as pharmacy to pharmacy, but we all really work well together. I love all the pharmacists in Hutch, and I've met a lot of the ones from Kansas, and we're all in this together, whether you're a Walgreens pharmacist or Dillon's, Walmart, any of the other independent pharmacies in the area. We all try to help each other as much as we can, because we know that we are all struggling in some way or another, and we're all just trying to help our patients. And so I guess just, you can come and you can talk to us about this if you want to, because I'm really passionate about it. I know that my dad and the other pharmacists are too. And a lot of the pharmacists around Kansas, after we had this pharmacy day, we're all super passionate about this. But just, you can ask questions, and you can always ask, hey, so if this wasn't on my insurance, would this be cheaper? Ask us that question, because we would love to work out a cash price with you. But we're just not supposed to say it. So.
Yeah, you can't start the conversation.
Yep.
I have one more question for you. I don't know if you'll do this or not. Do you want to sing the Medicine Shoppe jingle?
Oh my gosh, no. Maybe you can play it.
Okay, we can play
especially with my raspy voice right now. But no,
it's one of my favorite things
I
in the
know,
world.
it's so catchy. My dad had that made when I was little.
Really?
And so some people thought that maybe my mom sang it or something. No, none of us have singing voices and none of us sang that. But it is a very catchy jingle. He tried to change it a couple years ago to something else, and that didn't stick because it's just so catchy.
No, you'd have a revolt on your hands.
Oh, I know. People were like, "What is this?"
Jingle.
Yo, yeah, definitely.
I can't sing it either, but it's the Medicine Shop, Medicine Shop.
Drop your prescriptions off. The personal care that you'll find there will make you feel all better.
Yes!
Yep.
Yes! We got it!
Yep. Oh, man.
Thank you so much for coming on
Thank
today
you for
and
having
helping me
me
explain a very complicated issue and for reluctantly singing the Medicine Shop
Oh, my
jingle.
goodness. Yeah, cut that part out. Yes. Thank you so much. Have a good day.
I'd like to thank a few of the people who've helped make that podcast and Hutch possible. My son Mitchell Probst wrote and recorded the music for the show. Jenny Brigette put together some great graphics and promotional art. And Chris Acker helps overcome my mistakes to produce a great sounding product every episode. That podcast and Hutch is made possible through a collaboration between the Hutchison Arts and Culture Collective and Salt City Sound. They're working to bring resources and infrastructure to support art, music, and storytelling in our community. If you have an idea for your own podcast, reach out to them at podcasts@saltcitysound.net. If you enjoy that podcast and Hutch, be sure to subscribe and share it with all your friends. You can also help support this production by subscribing to thatguyandhutch.substack.com or by emailing me at thatguyandhutch@gmail.com to learn about sponsorship opportunities. Thanks for listening, and I hope you'll join us again next week.
A Salt City Sound production.